I work in a pathology lab. We test about 15,000 patients every day in my little lab. And the only disclosure I'll say, I'm employee of Sonic Healthcare, which is the third largest pathology company in the world. It's the largest in Australia, the largest in Europe, especially in Germany, and the third largest in the USA. The relevance of that is that we've got so much data and results. We see so many results. And a lot of my talk today is going to be showing you the data mining, if you want, of these results. What do they look like? What does the whole tested community look like? Now, many people think of data mining as sort of a peripheral view of the world. No, it's not. It's the real world. This is the entire clinical world that I'm going to be presenting to you. So it's not a biased view, and it's something that occupies me. Now, I've mentioned hemoglobin A1c, which people associate with glucose, and I'll be discussing that. What is A1c and how is it related to diabetes? How does it correlate with glucose? And then what we're interested in with metabolic syndrome is insulin. And once you start uncovering the relationships of A1c with insulin, then you're starting to dive into these other relationships of hemoglobin A1c. So hemoglobin A1c, hemoglobin is the red part of your blood, and it's composed of 4 subunits, alpha and beta subunits, and each of those subunits can have, at various places on it, glucose stuck to it. Glucose is a sticky thing, it glycates. And so wherever there's a positive charge, particularly on the end of the peptide chain, glucose can stick. And the higher the concentration in your blood, the more glucose sticks. It was described over 30 years ago, and it was described as this separation. Here's hemoglobin A0, that's got nothing stuck to it, and there's hemoglobin A1A, A1B, and A1C. And there's a whole lot of this A1C in this patient who was diabetic. And we worked out, well, what's stuck to the hemoglobin that makes it look different? It's glucose. And it got its name from this electrophoretic separation. And we knew that what is it that determines the amount of hemoglobin A1c in your blood? Well, it's the level of your fasting glucose or your 2-hour glucose. That's the parameters they had in these studies. So the glucose level is what determines the A1c level. In these studies, there was a little bit of suggestion that age was an independent variable. So here are the relationships between fasting glucose and 2-hour glucose and A1c. And people look at this and say, well, that's not a very good relationship. There's a lot of scatter around that line. How is that a predictable relationship? Because this is one glucose level. And anyone, say somebody with a hemoglobin A1c of 5, well, their glucose level may vary on the same day between 50 and 150. So it's not an unusual thing that there's this scatter. Your glucose varies much more than your A1c varies. I published a few papers on this correlation, and what's remarkable is that if you take a single glucose level, it predicts 50% of your hemoglobin A1c. So there's 50% can be predicted from one glucose level, which is pretty amazing, really. Now, in all of these studies, we're looking at different types of glucose, single glucose levels, and how well they might predict hemoglobin A1c. So fasting glucose levels are better than random glucose levels. Plasma samples, which are fluoride-preserved samples, are better than serum samples, which degrade with time. So there's a logic in that correlation. But the correlation is really barely above 50% for a single glucose level. And here's for a glucose tolerance test, the fasting level, the correlation is 0.63. 63% of it's predictable. And interestingly, a fasting glucose level of 7 equates to an A1c level of about 6.8%. So those 2 points are where we've defined diabetes, around those points. The 2-hour level, again, there's a bit more scatter, and a level of 11.1 for a 2-hour level, which is diabetes, equates to about 6.8. So they're wholly compatible in the way they predict those parameters. Now, what happens if you start combining levels? What about if we average the fasting and the 2-hour? Isn't 2 a better way to predict the A1C than 1? And so if we combine 2 levels or 3 levels, we start getting a better correlation. So 70% of the A1C is now predictable by 3 glucose levels, rather than 50% by 1 glucose level. And now in the DCCT study, which was a study of type 1 diabetics, they looked at 18, well, every patient had 3 or 4 glucose levels a day with a glucometer, and it'll run it over several days. So they had 18 glucose levels on every patient, which they compared against the hemoglobin A1C. And the correlation now starts to hit closer to 0.7. So the more glucose levels you have, the more it starts reflecting the hemoglobin A1C. And we can just keep going, because with these things now, we're not talking about 18 levels, we're talking about hundreds or thousands of levels. And this is from very early use of continual glucose monitors. It's 10 years ago, from someone who you might be able to read there. But there's the fasting glucose levels, or these are random glucose levels from the glucometer, and it gives you no idea of how truly glucose has changed over the day. So averaging 7 glucose levels is never going to tell you what glucose has been doing across the day. But when you look at that CGM average glucose and look at how well it predicts hemoglobin A1C, now the correlations are 0.9. So the closer we get to having lots of levels, the more average glucose matches hemoglobin A1C. And I did some fun extrapolations. How many glucose levels would you need to predict A1C perfectly? About 300,000. Which may sound like a lot, but that's a measurement every 30 seconds for 3 months. And 3 months is the lifetime of hemoglobin A1C. So if you could measure glucose every 30 seconds for 3 months, you would get a very close match to hemoglobin A1C in theory and in practice. Now, does that glycation, so does the glucose sticking to hemoglobin have anything to do with glucose sticking to anything else in the body? Well, there's a test we called fructosamine, which is glucose that's stuck to albumin, and the correlation between hemoglobin A1C and glycated albumin is virtually perfect. There are no curves in that line. At least for these 2 proteins, glycation indices match perfectly. Now, hemoglobin A1C, before we used to diagnose diabetes as a hemoglobin of 7 fasting or 11.1 2-hour, and then we moved to hemoglobin A1C above 6.5%. And these were the studies that came up with that figure, because we could see when that level got to that point, then suddenly patients started to get diabetic complications. This is retinopathy, this is the eye disease. So the same point could be made between a fasting glucose, a 2-hour glucose and an A1C. When people look at, well, what is it? If we can use them equivalently, fasting glucose or A1C, which one predicts complications best? A1C predicts it best. Because fasting glucose is too variable. We need too many glucose levels to really be able to predict these complications. And so no endocrinologist in the world relies on glucoses to predict complications. They use A1C. And in the these American and international standards of how do you diagnose diabetes, number 1 is A1C, and number 2, 3 and 4 are glucose related. And in Australia, very soon, the only way you'll have a glucose tolerance to diagnose diabetes is if there's something wrong with your hemoglobin A1C measurement. A1C is, for all intents and purposes, for 99% of people, the best measure of diabetes, its complications, and your glucose levels. Why did it take so long, 30 years, to work out that A1C was so good? Because 30 years ago, no two labs gave out the same number for haemoglobin A1C. And so, whereas nowadays, this is in America, 2010, much more consistent. So if you go to one lab, 6.5, it's going to be pretty close to 6.5 another lab. And this is in the Australian surveys, 2002 to 2018. And you can see the yellow bars there. In laboratories using this method, which is the one we use in our labs universally, 6.5 in one lab, could be 6.3 in another or 6.6 in another, but it's never going to be 6 or 5.5 or 8. So it's reliable now. Now these are some figures about, so diabetes is really judged by its complications, the damage to the eyes, the damage to the kidneys, and the damage to the nerves. And many of those are detectable in patients when they're first diagnosed. And we think of them as diseases of glycation. So glucose somehow has stuck to your kidneys and made them leaky. Glucose has somehow stuck to the blood vessels in your retina, made them leaky and they damaged. So it's all to do with glycation. Now that's different because haemoglobin, when it has glucose stuck to it, it still works as haemoglobin. Albumin, when it has glucose stuck to it, it still works as albumin. But some things in the body, when they have glucose stuck to them, it seems like it affects their activity. That's our understanding. So here, again, this is the haemoglobin A1C rates against the prevalence of retinopathy. And so here the haemoglobin A1C, once it gets to about 6.5%, the possibility of eye disease starts to rise. Now, I wanted to test this in the laboratory, but we don't have measures of retinopathy in my laboratory, and we don't have measures of neuropathy in my laboratory, but we certainly have measures of nephropathy, which is the amount of albumin that's leaking in the urine. And people have described that once your A1C gets above 6.5%, you start becoming albuminuric. So I wanted to test that. Now, the data that I'm talking about is 3 million haemoglobin A1C results matched against 2 million urine albumin results. And I can drill down to age groups. And so here in elderly women, this is the interquartile range, the range of albuminuria according to A1C. And you can sort of see that once you get to about 6.5, the rate of albuminuria starts to rise. And that sort of fits, well, yeah, that's why we diagnose diabetes at 6.5. What about in older men? Well, I'm not really sure it's 6.5 anymore. And what's really fascinating is what about young women? There is no relationship between haemoglobin A1C and albuminuria. So now this is really important to know because I can tell you it's pretty scary when you've got a young adult and they've got a raised A1C. You're worried that they're going to be developing kidney disease and be on dialysis in the next 5 years. Well, there's very little evidence for that. Now you might think, what is the difference between young and old? And it's to do with the passage of time. And that's something that we neglect to think about. And this is the take-home message in this talk. So pre-diabetes. So we talk about diabetes and the A1C predicts proteinuria somehow, maybe not in everyone. But pre-diabetes. Pre-diabetes is before you get to 6.5. So, and that we used to talk about that as the deadly quartet, obesity, dysglycemia, dyslipidemia and hypertension. And we called it Syndrome X because we didn't know what it was due to. And people didn't like that because we should know what the most common disease is. So we called it metabolic syndrome, and now it sounds like we know what it's due to, but we don't. And the bottom line is probably what it's due to, which is insulin resistance. Now, in various parts of the world, we have defined pre-diabetes by A1C. In America, if you've got an A1C between 5.7 and 6.4%, you're considered pre-diabetic. In a New Zealander, because they like to be a bit different, it's 5.9 to 6.6%. They're much more pragmatic about these numbers. In Australia, we don't say anything. We say, well, it could be around 6. We're not sure. So can hemoglobin A1c predict metabolic syndrome? Of course it can. And in this study from the New England Journal about 6 or 7 years ago, they looked at the rate of hemoglobin A1c before you develop diabetes and the things that change. And the things that change are everything in the metabolic syndrome. Hypertension rises, triglycerides rise, HDLs fall. So I'm interested in this now. I've got all those numbers in my lab. What do they look like? Well, let's go back to insulin first. What is the relationship between hemoglobin A1c and fasting insulin? And it's a bit like glucose. The higher your A1c is, even into the, well, it seems like even into the diabetic range, the higher your fasting glucose is. You know, a healthy level is under 10, but levels around 20 may be in this borderline diabetic range. So that's linear, so it just seems to rise. But it doesn't take much. Almost every type 2 diabetic can make 20 units of insulin. So that's why it keeps rising, because they can make it and they will make it. What about, now I'm just changing the axes there so you can see what happens with the 1 hour insulin level. So this is 1 hour after a 75 gram glucose load or 1 hour after a meal. When you've got a normal A1C, so you're healthy, your insulin level is 60 to 80. When you've got an A1C of 6, it's closer to 100. And then when you're diabetic, it's normal again. Why hasn't it gone up? Now, in the 2 hour level, which is interesting, it sort of rises and plateaus rather than rising and falling. But why doesn't it keep going up? I'll come back to that question. There's another measure we have in the laboratory, which is insulin as it's released from the pancreas is broken down to insulin and C-peptide. And the nice thing about C-peptide, insulin sort of hangs around for a few minutes and then disappears, whereas C-peptide hangs around for hours. So it's a much better indicator of how much insulin you're making. So when we look at the relationship between A1C and C-peptide, it rises to about 6.5, and then in the diabetics, it's not higher. Diabetics do not make more insulin. Type 2 diabetics do not make more insulin. Some make, it sort of plateaus out at best, but it falls in many patients. So why don't we just keep making more and more insulin to keep that glucose under control? And it's because of this concept of the islet cells burn out. When we look at the pathology in islet cells, in type 1 diabetes, the islet cells are surrounded by the immune system, which are going to kill it off. But in type 2 diabetes, it's a graveyard. It's just hyaline tissue, which is just dead cells, which we can't remove. So what happens in type 2 diabetes, it's not that you don't want to make more insulin to try to control it, but you can't because you're destroying those islets by overworking them. So that's why it seems that, in diabetes, the insulin levels are not much higher and perhaps lower than they are in pre-diabetes. So in my mind, pre-diabetes is at hyperinsulinemic state, and type 2 diabetes is an insulin-resistant state where you can't make enough insulin. Now, here are the lipid levels against A1C. Whilst there's been some indication in previous, you won't see this in any publication. I do have to publish it eventually, but anyway. So what does cholesterol levels do as your A1C increase in men and in women? So in women, it just seems to it climbs once you get out to A1Cs of 10 and things are out of control. But in men, it rises, peaks at about an A1C of 6 and then falls back at 6.5. So in a way, it's reflecting the total cholesterol level, which I don't want anybody to be worried about because it's a meaningless number, but there is something going on here. The total cholesterol level in men is behaving like insulin, going up and coming down in the pre-diabetic phase. So we need to understand that more. Well, what happens with triglycerides? Triglycerides rise at about 5.2, peak at 6, and then fall a bit. They just don't keep going up in diabetes. The highest levels are in pre-diabetics or severely, very badly controlled diabetics. And the same thing in men. The triglycerides are peaking in this pre-diabetic. So in a way, the triglycerides have got something to do with hyperinsulinemia, not to do with glycation. This is the ALT level. The ALT is something released by the liver and usually released in fatty liver. So when your blood's choked up with fat, guess what? Your liver's choked up with fat. And that particularly occurs at this pre-diabetic phase. Fatty liver is a common thing that you see, more commonly see in pre-diabetics than in diabetics. Here's HDL, and in a way, so the exception proves the rule, HDL dips in the pre-diabetic phase and then comes back up in the diabetic phase. So again, the HDL and triglyceride are related to the hyperinsulinemia. LDL, as we know in the low-carb community, rises. So it's rising in that phase, but you have to have some caution. You remember this is a calculated parameter, so it's got all the distortions of whatever else is going on. Now, if people have heard my podcast, I think that I'm most interested in total cholesterol HDL ratio. For me, it predicts small dense LDL better than the other simple ratio. So what happens to that ratio according to A1C? Well, it shows this massive peak in the pre-diabetic phase in men and in women. The levels are different in men and women because women have more HDL, but the pattern is the same. And if you prefer the trig HDL ratio, well, it does the same thing, but I don't think it's quite as profound as the other ratio. Okay, so now if I've just said hyperinsulinemia, small dense LDL, well, that means heart disease, doesn't it? If your small dense LDL is rising when you're going from 5.5 to 6, shouldn't you be getting heart disease? And people have known that. The risk of heart disease rises before you become diabetic, according to the A1C level. And in the paper by Levin, this is the risk for heart disease, according to A1C, and it starts at 5.5. And on this exponential scale, it's not really climbing exponentially forever. It's sort of plateauing off. Now, in the laboratory, I have got a measure for cardiac damage, and it's called a troponin test. One of the, I don't think it's that stupid thing that the doctors do. Troponin is something we usually use to detect a heart attack. So in this study, I've taken away all of the hospital troponins, and I've only including the primary care troponins, where doctors are thinking, oh, I think there's something wrong with this patient's heart. I'm not going to send them into hospital, but I want to see what their heart's like. And so now there's a whole lot of different lines here. So you can see generally that it's reflecting what Levin showed, that the risk of a raised troponin, and these are actually controlled by age. So the risk of a rising troponin in middle-aged men rises between 5.5 and 6.5. So that we know. In the elderly, it's much the same. But here are the young people, under the age of 39 for women or under the age of 49 for men. There's very little relationship between A1C and troponin. So that's exactly what we found with that urine albumin issue. Young people do not. If you've got an A1C of 8% as a 20-year-old, you're not going to die of a heart attack tomorrow. You're not going to be microalbuminuric tomorrow. These things take years to develop. And this is a recent study by Monash University that look at the risk of heart attacks in type 1 diabetics. And they found no relationship of A1c with heart attacks in type 1. No relationship. The strong relationship was with time. You have to have type 1 diabetes for 20 years before you start getting heart disease. You have to have type 1 diabetes for 20 years before your troponin starts to rise. You have to have type 1 diabetes for a long time before you start getting nephropathy. So they did find that HDL was an independent factor, but generally they found that time was the biggest determinant of all of these pathologies. And time is something that we miss out on in the studies. Whenever you see a study, how old were those people? Because that's going to be the biggest determinant in what that study finds. So in summary, A1c is a better measure of abnormal glucose than glucose. It's a consistent measurement. It's a preferred, and therefore it's a preferred test for diabetes. It correlates with albuminuria in time. It should be the preferred test for pre-diabetes, rather than not having any A1c criteria in Australia or using glucoses elsewhere. Pre-diabetic A1c associates with hyperinsulinemia, associates with dyslipidemia and fatty liver, and associates with cardiac damage. So in Australia, the only reason you're allowed to have an A1c measured and paid for by the government is if you're at risk of diabetes. But I really think that if you're at risk of heart disease, you need to know where you are on that journey, and that A1c may provide the best indicator of where you are on that journey. It's a relatively cheap test compared to LDL sizing and so on. And a lot of doctors have got a low threshold for ordering it, because in a way, a patient with normal weight could have diabetes. But I think it's an underutilised test, and a test which will only improve with time. And it's a single measure which summarises all of those issues of insulin, triglycerides, heart disease, kidney disease. But don't overreact to it in young people, because they've got time to get their act in order. And just an acknowledgement, so that's about 10 years ago, and that's the person that taught me more about diabetes than anyone. Thank you.